for pathophysiologic purposes. We were talking about GI bleeding, and so we're going to take up diseases of the liver today. And basically, the approach of the book is they talk about the different functions that the liver subserves, and they tie it to the dysfunction, the abnormalities that you can see in people who have liver disease as a result. So, for example, because the liver plays a role in detoxifying various substances in the blood, patients that have end-stage liver disease are prone to the development of encephalopathy or hepatic encephalopathy. Much like you see in patients with uremia, the kidneys are also responsible, have a role in detoxifying. Patients with liver disease can develop hepatic encephalopathy. We'll talk about that. Because of the role of the liver in glucose homeostasis, patients that have end-stage liver disease are also prone to the development of hypoglycemia. You'll see this, for example, in alcoholics with end-stage liver disease. Again, because of the role of the liver in the production of serum proteins, particularly albumin, patients that have liver disease tend to have lower serum albumin, so they have hypoproteinemia, hypoalbuminemia, and everything that goes along with that, including possibly third spacing, lower extremity edema, and of course, remember that there's a relationship between the albumin and the normal serum calcium, so you have to be talking about that, but we will talk about that. And then, of course, because of the liver's role in getting rid of bilirubin, patients with end-stage liver disease are prone to the development of jaundice as well. And by the way, the production of protein isn't limited to just albumin. The liver produces other proteins as well, including clotting factors. So patients with liver disease can develop a coagulopathy. So you'll see that there's a whole host of things that go along with the end-stage liver disease. So let's talk about the first topic that they take up is jaundice and the role of the liver in bilirubin metabolism. And if you look at figure 410 on page 82, you'll see that what they do is they divide the topic into, they divide hyperbilirubinemia or jaundice into two categories. You have unconjugated jaundice, unconjugated hyperbilirubinemia, and conjugated hyperbilirubinemia. Unconjugated is also known as indirect, and then conjugated is the direct. And you see that there's a list of entities, disease entities that are associated with each of these types of hyperbilirubinemia, and they correlate how each of these disease processes, the step at which the process for the excretion of bile goes awry. Okay, so the hemolysis, for example, patients that have hemolysis or increased production of increased breakdown of red blood cells, and so release of hemoglobin into the circulation, they're going to have increased indirect bilirubin, increased unconjugated bilirubin. And so what you'll see in these patients when you do a serum, when you do liver function tests, when you look to the bilirubin, is that their indirect bilirubin will be elevated, okay, but not the direct bilirubin. Okay. Let's talk about some of the disease entities that you've probably not seen before. The first one that they talk about is also associated with unconjugated hyperbilirubinemia is Gilbert syndrome. And Gilbert syndrome is a syndrome that's due to the decreased activity of an enzyme called glucuronil transferase. It's a GLUCURONYL transferase, glucuronil transferase. And you see jaundice, it's associated with jaundice under conditions of exertion, under conditions of stress, under conditions of fasting. So you'll sometimes notice this on patients, let's say, who are having a fasting blood work done, and you'll notice a mild elevation in serum bilirubin. But if they're not fasting, they don't have it. Okay, so that's Gilbert syndrome. Infections can also produce hyperbilirubinemia in patients with Gilbert syndrome, and it doesn't have any serious consequences. It is. I'm sorry, what's the matter? Question? No. It doesn't have any serious consequences. It's the most common cause, hereditary cause of hyperbilirubinemia. It's a benign entity. They need to be able to recognize it. Again, you can see in patients who mild elevation of the bilirubin in patients who are stressed or fasting or whatever. Crigler in the jar is another syndrome associated with the abnormality in the enzyme, but it is more serious, and I think it's much rarer than Gilbert. So hemolysis, CHF. Gilbert syndrome, Crigler in the jar syndrome are all associated with an increase in the indirect bilirubin, the indirect fraction of the bilirubin, unconjugated hyperbilirubinemia. The other entities that they talk about, Dubin-Johnson, Rotor, and obstructive jaundice are all associated with increase in conjugated bilirubin or direct hyperbilirubinemia. So Dubin-Johnson and Rotor syndrome are non-cholestatic causes of conjugated hyperbilirubinemia, as opposed to, again, biliary tract obstruction, which are cholestatic causes of hyperbilirubinemia. Jaundice is going to be, you probably talked about this in the physical diagnosis, but jaundice early on is going to be most easily recognized with scleria of the eyes, under the tongue. Those are usually the places where you would look. And usually you have to have a serum bilirubin. It's got to be in excess of 2.5, total bilirubin in excess of 2.5 in order for it to be visible. They talk about some of the other findings that can be associated with hyperbilirubinemia. So they point out that patients can develop darkening of the urine. They can develop clay-colored stool. Particularly, actually, that's specific for cholestatic jaundice. So if you have a biliary obstruction or impaired secretion. And some of the symptoms that patients can get, besides the sign associated with the sign of jaundice, patients can complain of pruritus because the bile pigments, the bile salts are irritating to the nerve endings, so the patients complain of pruritus. And bilirubin, especially when it gets very high, like up into the teens, is toxic to the sinus node. And so patients with hyperbilirubinemia can develop sinus bradycardia and I guess at some point can even develop sinus arrest. So you need to be aware of that. So when you have a patient that presents with hyperbilirubinemia, again, when you get lab tests back, you're going to get back a total bilirubin, a direct bilirubin, and an indirect bilirubin. Okay, and the total bilirubin is the combination of some of the indirect and the direct bilirubin. And so what you want to do is you want to look to see, am I dealing with an indirect hyperbilirubinemia or am I dealing with a direct hyperbilirubinemia? And that's going to help you approach the patient. Okay, am I dealing with something like hemolysis, congestive heart failure, one of these syndromes, Gilbert's or Crigler-Najjar, or am I dealing with conjugated hyperbilirubinemia? Right? So that's what you're going to do. Now, besides the bilirubin, the other things that we can do to assess the liver in terms of laboratory evaluation are the so-called liver function tests. But they're misnamed, okay? The LFTs is the name ascribed to AST, ALT, alkaline phosphatase, where AST is aspartate aminotransferase, ALT is alanine aminotransferase, and these things have changed names, by the way. They used to be called SGOT and SGPT. SGOT is AST, and SGPT is ALT. But it's a misnomer because these tests really don't measure liver function. Okay? If you really wanted to measure liver function, again, you want to measure how well is the liver doing at detoxifying substances, what role is it playing in gluconeogenesis, production of protein, all of those things. These things don't really measure liver function, but they're called liver function tests. Okay? So these enzymes, AST and ALT, are enzymes that are released into the circulation when there is an inflammatory process that involves the liver, or some type of process that involves the liver. And again, as the book makes clear, they're markers for injuries to hepatocytes. Alkaline phosphatase, which is the other enzyme that's measured there, is a marker for biliary tract obstruction. It's a marker for cholestatic liver injury. So when you approach the patient that has an abnormality of the liver function test, okay, so there's an abnormality on the LFTs, so AST, ALT, and alkaline phosphatase, you're going to divide those patients up into two categories. The first is the patients that have a hepatocellular pattern, or hepatitis pattern. And the second are the patients that have a cholestatic pattern. Now, we're going to talk a little bit about how these two groups of patients can be distinguished. So patients that have a hepatocellular liver injury pattern have a predominant increase in the AST and the ALT. So if you look at the AST and the ALT and the alkaline phosphatase, what's going to jump out at you is how abnormal the AST and the ALT are. Okay? Oftentimes the AST and the ALT can be elevated to 10 to 15 times the upper limit of normal. Alkaline phosphatase, on the other hand, is often elevated in these patients as well, but the elevation is much, less than 2 to 3 times the upper limit of normal. In patients that have cholestatic liver injury, you'll see a predominant increase in the alkaline phosphatase, greater than 3 to 4 times the upper limit of normal, and you won't see the associated dramatic increase in the ALT and the AST. Let's talk about some of the causes of each of these categories of disease, okay? So in terms of the hepatocellular liver injury, again, predominant increase in the AST and the ALT. Not surprisingly, the paradigmatic example of that is viral hepatitis, okay? So viral hepatitis is the paradigmatic example of hepatocellular liver injury. We're going to talk about the viral hepatitis in a little while. But you can also see a hepatocellular liver injury that's the result of a drug reaction, so drug toxicity. Some drugs are toxic to the liver. So, for example, cyanate, which is used in the treatment of tuberculosis, can be associated with liver toxicity. You need to watch out for that. A third cause of hepatocellular injury is steatohepatitis, which is also known as fatty liver. You see that in patients that have diabetes, other things. The fourth cause is autoimmune hepatitis. And you can have some metabolic abnormalities that are associated with hepatocellular liver injury too, including Wilson's disease, which is a disease of copper metabolism, and hemochromatosis, which is a disorder of iron metabolism, iron handling. So those are the let's say the 5 common causes of hepatocellular liver injury. In terms of cholestatic liver injury, the common causes include drugs. So drugs, you have to remember, can do either or. Okay, they can produce either a hepatocellular or a cholestatic liver injury. Drugs is one. A disease entity, which we haven't talked about yet, but we'll read about the book, primary biliary cirrhosis can cause this. Sclerosing cholangitis. You remember what disease that's associated with? We talked about it a little bit. We mentioned it in the past. It's one of the inflammatory bowel diseases. No, ulcerative colitis. It's most commonly seen in ulcerative colitis, primary sclerosing cholangitis. Autoimmune cholangitis. So just like you can have autoimmune hepatitis, you can have autoimmune cholangitis. Sarcoidosis, or other infiltrative or neoplastic diseases. One other thing about cholestatic liver disease. Again, the thing you're going to look for is an elevation of the alkaline phosphatase. But did you have lab medicine? Have you been studying lab medicine? Did you study alkaline phosphatase in lab medicine? Okay. So alkaline phosphatase is an enzyme that's produced in the liver, but it's also produced in bone. Okay. And so when you find an elevation of the alkaline phosphatase, the differential diagnosis becomes, okay, liver disease, bone disease. You have to figure out which one it is. And one of the ways to do that is there's another enzyme called gamma glutamyl transpeptidase, which is abbreviated GGTP, and GGTP is not found in bone. So if you have an elevation of the alk phos and the GGTP is normal, it suggests that you're dealing with bony disease. If you have an elevation of the alk phos and the GGTP is abnormal, it suggests that you're dealing with liver disease. So GGTP can be used to distinguish between elevation of alk phos due to liver disease or due to bony disease. Couple more things I want to say about the stuff that we've covered so far. So, for example, we mentioned the importance of sarcoidosis, or we mentioned the role of sarcoidosis as a cause of cholestatic liver injury. It's important for you to start trying to remember the stuff that we talked about as it relates to sarcoidosis before, because you have to be able to tie all of this stuff together and recognize the patient that has sarcoidosis or that has a particular presentation. You know, am I dealing with sarcoidosis, and what else do I have to be looking for? So you remember, patients that have sarcoidosis have what type of lung disease? I'm sorry? No, but they don't have cancer. They have restrictive lung disease, right? They have restrictive lung disease, okay? It's actually very interesting, sarcoidosis, because sarcoidosis is a restrictive lung disease that actually has a tiny obstructive component. So it's actually very interesting. But they have the restrictive lung disease, okay? And what do they have in terms of cardiac disease? Restrictive cardiomyopathy, okay? So now you know that how sarcoidosis can affect the liver as well, okay? Eye and the skin are the things that we always think about with sarcoidosis. So they can have eye findings. Sometimes the diagnosis can be made by sending the patient to an eye doctor. And they often present with weird rashes, okay? So just be aware of that. You need to be able to, when you read about something that you've read about before, I want you to be able to call that stuff up again. The other thing I want you to pay attention to when you read the book is there are differences between conjugated hyperbilirubinemia, for example, and unconjugated hyperbilirubinemia in terms of signs and symptoms and things that patients might present with. And so, for example, if you look at the bottom of page 83, they point out that if a patient reports that they have dark urine in association with hyperbilirubinemia, then that tells you that they're dealing with a conjugated, that you're dealing with a conjugated hyperbilirubinemia, because it's the conjugated hyperbilirubinemia that is water soluble, okay? And unconjugated hyperbilirubinemia is not going to find its way into the urine. So that's an important distinction. Now, so for example, if you're told about a patient that presents, and this is how he presents, and the question is, okay, does he have conjugated or unconjugated hyperbilirubinemia? It would be important to recognize, hey, the dark urine doesn't happen in association with unconjugated hyperbilirubinemia. Okay? So, just make sure you pay attention to those details. All right. Any questions about anything that we talked about so far? Questions about hyperbilirubinemia or abnormal liver function tests? Okay. So the next topic that they talk about are, I guess, what the book suggests would be the true liver function tests, which are bilirubin, which we've already alluded to, serum albumin, prothrombin time, or the PT, talked about some of these before. The PT, so we talked about the albumin, we talked about the bilirubin. In terms of the PT, they point out that the prothrombin time is a measure of the functioning of the extrinsic pathway of the clotting cascade. Have you talked about the clotting cascade physiology or any other context so far? No? What? Okay, in what class? Okay. All right. So one of the things that when we talked about the hepatocellular disease, the hepatocellular liver injury, that pattern associated with elevations of the predominant elevations of the AST and the ALT, we talked about Wilson's disease. I said that was one of the metabolic diseases that can do it as well as hemochromatosis. Okay, you'll see when we get to endocrinology that hemochromatosis is also referred to as bronze diabetes because it produces discoloration of the skin because of deposition of iron, and it also produces diabetes because of infiltration of the pancreas and pancreatic dysfunction, endocrine pancreatic dysfunction. But this is a Kaiser-Fleischer ring are findings associated with Wilson's disease, and you see this ring over here. That's the Kaiser-Fleischer ring, and that is the result of deposition of copper in the tissue over there. So this is seen in the patient that has Wilson's disease. Okay? And again, Wilson's disease is going to be associated with predominantly a hepatocellular type pattern on liver function tests. One of the things that they point out at the I don't have the cascade to show you. I guess we'll get to the clotting cascade when we get to hematology. But just understand, just as you've already been exposed to, there's two pathways in terms of coagulation. There's the extrinsic pathway and the intrinsic pathway. And the PT, prothrombin time, is associated with the extrinsic pathway, and it's warfarin that affects that pathway. The PTT is associated with the intrinsic pathway, and heparin affects that pathway. Okay? So when you measure the PT is the one that you're going to have problems with in patients that have liver disease because of the role of the liver in producing factor 7. It's going to be the rate limiting step in that cascade. At the bottom of the page, it says elevated prothrombin time is more associated with acute liver disease, while a decrease in albumin is generally associated with chronic liver disease. And I guess that's true in general, but you should be aware that, for example, if patients have catastrophic or fulminant liver disease, where they do something that basically wipes their liver out, like for example, ingest an overdose of Tylenol or eat a poison mushroom that they didn't know was poison, then you can actually see, even in the you can see, all bets are off, and you can see complete liver dysfunction in every way. Okay, so let's talk about the first, some of the diseases, and the first group of diseases that they talk about are the viral hepatitis. And as I said before, viral hepatitis is the paradigmatic example of hepatocellular liver injury. And The viral hepatitides are discussed in figure 411 at the bottom of page 84. And the table is pretty good. So I'll just focus on a couple of things to just bring your attention to it. So you got hepatitis A, B, C, D, and E. The first thing you want to ask yourself is, all right, as you approach each of these different diseases, okay, how does the patient contract the disease? So some forms of hepatitis are contracted through the fecal-oral route. Hepatitis A and hepatitis E are contracted through the fecal-oral route, whereas the other forms of viral hepatitis are contracted either through like a needle stick through the blood, basically, or through sexual contact. Okay. The second thing you want to ask yourself is, okay, if the patient gets this disease, what is the likelihood that the patient will develop fulminant hepatitis, which means what's the likelihood that they'll slough their liver? Okay. And second of all, what's the likelihood that the patient will go on to develop chronic hepatitis? Okay, so for example, you look at hepatitis A, transmitted orally, you see that there's a 1% incidence of fulminant hepatitis. Okay? So it's not a completely benign disease, at least for that 1% of patients who get fulminant hepatitis. But they don't develop chronic disease. Hepatitis A is not associated with chronicity. Okay, so for each type of hepatitis that you are learning about, you want to know how's it transmitted. Okay, what is the risk of developing fulminant disease, and what's the risk of developing chronic disease? Contrast hepatitis A, for example, with hepatitis C, which is notorious for resulting in chronic disease. So you see 50% of patients with hepatitis C will get chronic hepatitis. Now this is going to be changed probably by the newer drugs, but historically 50% of patients with hepatitis C develop chronic hepatitis, and of those, 20% go on to develop cirrhosis. Because cirrhosis results in probably because it results in distortion of the architecture and cell-cell communication. Some of these hepatitides are also associated with the development of hepatocellular carcinoma. So you see, for example, that hepatitis C and hepatitis B have an increased risk of the patient developing hepatocellular carcinoma. It's important to take note of as well. One other thing to take note of is the special case of hepatitis D. Hepatitis D can happen in two ways. So a patient who has pre-existing hepatitis D can get super infected with hepatitis D, and he can present with, let's say, a new onset of hepatitis, but it's D on D hepatitis. Okay, so if he has chronic hepatitis B, he can develop super infection with hepatitis C. The other thing that can happen is patients, as the book makes clear, patients can be infected with both organisms at the same time. The last thing that you want to take note of with each of these diseases is what do you look for? What do you look for to make the diagnosis serologically? And also, what's the incubation period? So, for example, hepatitis A, 2 to 6 weeks after the exposure is when the patient develops the illness. 2 to 6 weeks after the exposure is when the patient develops the illness. Hepatitis B is 2 to 6 months. Hepatitis C can be anywhere from 2 weeks to 6 months. Okay, so it's important to know what the incubation period is, because depending on when you think the patient's exposure was, it might give you some insight into what's most likely. Um, This is what I was looking for in the slides, but it's not there, so let's just spend a second talking about it. Have you guys seen this before? Okay, so you know that this is the course of the patient that has hepatitis C. Remember we said about 2 to 6 months when they present, so you see it's happening at about 2 months where they develop symptoms. Okay, and you see that the first thing that happens is you see the appearance of the hepatitis C surface antigen in the serum. Okay, and then that peaks, and then resolves. Okay, the next thing you see is the appearance of the anti-hepatitis B core and the IgM anti-hepatitis B core. And what happens then is that, and then later on, in the patient who's clearing the virus, who does not go on to develop chronic disease, he or she develops the anti-hepatitis B surface antigen. Okay? But what you see is that there may be a period after which the patient clears the surface antigen and before he or she develops the anti-hepatitis B surface antibody. There may be a time where they don't have either of those things, and the only way you can be sure that they've been exposed is to look for the IgM. Okay, so that's the same window period, right? So you should be reasonably familiar with the time course. Okay, so just keep that in mind as you look at table 84. Okay. Let's finish page 84 and then we'll take a break. We talked about drug reactions. We said that drug reactions can cause either a hepatocellular picture on LFT abnormalities or a cholestatic picture. And then steatohepatitis or fatty liver, hepatic steatosis, which we talked about as another cause of hepatocellular dysfunction. They point out that you can have that in patients that have alcohol abuse, certainly in patients that have diabetes, patients that have obesity, and they actually in with that they lump another finding that is kind of important. They point out that patients that have alcoholic liver disease it produces a characteristic abnormality of the ratio rather of the ALT and the AST. So the ALT ratio, AST is elevated more than the ALT in a 2-to-1 ratio or thereabouts. Now that used to be easier to remember because AST was SpOT, ALT was SpQT, so SpOT is sort of like EPOH. So anyway, that's the way I remembered it. So but anyway, AST, now you have to remember 2 steps. AST is SpOT, and that goes up with more with EPOH than ALT does. All right, so let's take a break here, and then we'll come back and talk about some of the other diseases of the liver. Try and finish the GI stuff today.